good evening po sa lahat, saan pong panig ng mundo kayo naroon. Welcome to our 225th episode of the Health Updates webinar series. Thank you for being part of our credible online community, and for all those who have just discovered us for today, welcome po at sana po marami po kayong matutunan sa ating very interesting topic, something that people may not necessarily be aware of, pero lagi po itong nangyayari at paano po ba mas magiging informed yung lalo na po yung mga nanay po na mga anak po, no? So the landscape po of obstetric care, it has really evolved significantly. Meron pong tinatawag na vaginal birth after cesarean, yung po magnganganak po kayo ng normal after po kayong may paunang cesarean section. Ito po ay lumabas na po. It's a viable and often preferred option po para po sa maraming kababaihan. So while cesarean sections remain unnecessary and life-saving procedure in certain circumstances, the increasing recognition of the benefits associated with vaginal or normal delivery after a cesarean po, it has prompted that renewed focus as a safe and effective alternative for eligible candidates. So in this week's episode, we will be discussing the critical aspects and best practices, yung po tinatawag po nating VBAC. Also exploring ano po yung evolution po niya, ano po ba initial concerns, pwede po magkaroon ng uterine rupture, and up to present day, ano po ba yung mga robust research and refined clinical protocols na meron po tayo to establish safety and efficacy. We'll also dive into ano po ba yung selection criteria, sino po ba eligible candidates for VBAC, what are the factors that contribute to the successful outcomes, and identify situations where VBAC may not necessarily be advisable kahit po yun po yung gusto ng ating pasyente. So sit back, relax. We are very, very lucky, very fortunate po to have a couple of experts po on the topic, and we hope to be able to gain practical tips po, no, and an understanding po for VBAC candidates, more specifically, and what's the appropriate use of intervention, especially when necessary. This is the Health Updates program, and I'm your host, Dr. Raymond Francis Sarmiento. Always a pleasure to be with all of you during a regular Friday. Also, my pleasure and honor to host this program together with one of our program stalwarts, Dr. Stella Marie Legazpi. Ma'am Stella.
Good afternoon, Dr. Raymond, and welcome to our participants here in the live broadcast of the Zoom webinar, and to all those watching via TV live streaming via TVUP YouTube channel, as well as the UP System Facebook page, the TVUP Facebook page, and TVUP Signal Channel 101. Our panelists for today are very esteemed obstetrician gynecologist, Dr. Minifreda Reyes and Dr. Luisa Aku. Our new program is now called Health Updates. We have done a little bit of reformatting for our program, but we are still maintaining the same high quality and then leveling up to take a closer look at the existing and emerging health problems and issues in the Philippines today and in the rest of the world. So both our speakers are very known obstetrician gynecologists, and they will explain what is trial of labor after cesarean section. So sit back, relax, and let's listen to their talk. Going back to you, Raymond.
Thank you so much, Ma'am Stella. So before we dive into ano po ba yung kahalagahan, the importance of patient education and shared decision making, especially for anyone who's seeking an understanding of the options that are available for childbirth after a prior cesarean section, we will first dive into ang tinatawag po nating person on the street video. Yung po ating person on the street video or POTS video, something of an awareness check. We want to get the pulse of the common folks on the street on their understanding of the topic at hand. Questions that we pose to our interviewees. Ano po ang alam po ninyo tungkol sa cesarean section? Narinig nyo na po ba na maaring manganak ng normal kahit na cesarean na po nung una? At sa tingin po ba ninyo ay maaaring manganak ng normal delivery ang dating na cesarean? At ano po sa palagay ninyo ang advantage, benepisyo ng panganganak ng normal kumpara sa cesarean section? Please watch this.
Naririnig ko na, lalo na sa kumari ko kasi 3 beses siyang nasesaryan.
Pag cesarean, parang hindi mo kayang maglabas ng normal. Kailangan mong isesaryan para maligtas mo yung anak mo, ikaw din.
Ang alam ko sa cesarean ay hindi bumubuka yung pelvic bone nila kaya sinisesaryan sila.
It's a kind of surgery for birthing.
Sabi, ang pagkakalam ko kasi sa cesarean, hanggang 3 baby lang daw ang pwede nun. O na CS na ng 3 beses.
So, nahihirapang ilabas yung bata dahil mayroon kasing tendency na hindi kasya yung ulo nila or lumalaki or humahaba yung ulo nila pag pinipilit siyang ilabas.
C-section usually in-advise ng mga doctors if emergency cases or if the place of the baby in the womb of the mother is not normal or yung paglabas niya is mahihirapan yung mother. So, ina-advise ng C-section for safety ng mother and ng baby.
Alam ko lang sa dito yata sa tiyan inaano. Parang ang alam ko lang parang mas mahirap yata yung cesarean kasi sa normal na panganganak.
Depende sa kondisyon ng nanay kasi meron akong kakilala na kumadrona, siyam yung anak niya, 6 yung cesarean na una, tas less yung 3 na natira is normal, dire-diretso na siya.
My son is a C-section. Yung birth niya is C-section. He's my only son and nagawa yung procedure because kulang na raw yung water in my tummy pa na nasasabi yun. And kailangan daw na i-C-section immediately. So, urgent need siya.
Cesarean parang delikado ng mga anak ng normal o walang sure. Kasi ang mga sinisisaryan lang po kasi yung maliliit yung labasan ng baby or wala sa posisyon ng baby.
Kasi yung friend ko, nung sa 3 niyang anak, sa 2 niya anak cesarean, nung pinakabunso niya, normal niya i-deliver yung kanyang so pwede pala yung kahit na sunod-sunod kang cesarean, pwede ka palang manganak ng normal.
Yes po. Basta lang yung pacing or yung gap ng year should be more than 3 years. Hindi yung tuloy-tuloy yung birthing stage.
Pag normal kasi, yung na doon mo nararamdaman yung hirap, sakit, pag-deliver lahat. Ang cesarean po kasi, ikaw pwedeng mamili na ganito oras po ako pwedeng hiwain, hindi ko na mararamdaman, pwedeng hindi ako mag-deliver, pwede ko hindi maramdaman yun, ihiwain ka na lang po. Mas malaki ang difference.
Meron naman, every 3 years ang sinasabi nila, pero yung iba, ang ginagawa nila, pag naka-3 na sila na, na sunod-sunod na anak, hindi na daw pwede magbuntis ang mga nanay.
I experienced it there kasi some of my friends who gave birth normally, nababalik yung shape ng body nila. So, hindi after a month, pwede na sila agad, upon birth, pwede na sila agad maggagalaw.
Possible naman kasi depende nga yun nga sa kondisyon niya, sa lakas ng pangangatawan niya. Kaya yung iba, kaya, pero kadalasan ngayon, normally, pagka nagsimula na siyang cesarean, dire-diretso na. Pero yung panahon noon, pwede.
Or kumilos ng normal. Well, for C-section kasi meron talagang time na dapat i-heal mo muna yung sugat. Like 1 month to 3 months, yung medyo tawag nito, hindi ka pa comfortable na magagalaw because baka nga yung hiwa ay mabukas daw or something na may mangyari. So, yung carefulness mo to move, yun.
Alright, thank you so much, TVUP. Very, very interesting po, no? In terms of, I think that's one of the longer PATS videos that we may have had. But we're very, very grateful to the webinar team for coming up with this interesting set of interviews po, no? Before we dive right into the webinar proper, so we always have the standard panel discussion format wherein our speakers will present, and that will be followed by a Q&A session. And for all those who are asking, certificates of attendance will be given to those who have watched at least 50% of the webinar duration. If you have any issues or may not have received your certificate po, no, please email us at our up.edu.ph email address. We'll get our webinar underway. Dr. Estela will introduce our main speaker for today.
Our main speaker is Dr. Minifreda Reyes. She is a senior consultant at the Department of Obstetric and Gynecology at the St. Luke's Medical Center in Quezon City. She has been the chair of the Philippine Board of Obstetrics and Gynecology in 2021 and is the chair of the Department of OBGYN in St. Luke's Medical Center from 2012 to 2016. She is also an associate professor at the St. Luke's College of Medicine. And now she is our speaker. Thank you, Manny, for gracing our PBUP. And now it's up to you now. Thank you.
Good afternoon, everyone. And thank you so much, dear Stella, for that introduction. I hope I'm coming loud and clear.
Loud and clear, ma'am. Loud and clear. But please feel free to share your slides. All right. Go ahead, ma'am.
So I'd like to start my presentation by stating the reason for this topic. And why I think there should be a conversation or a discussion about cesarean section, particularly cesarean section rates. There has been a staggering increase in the rates of cesarean section during this last few years, and this has been a global concern. So if you will check out these graphs, from 1970 in the first graph to the last graph in 10 years ago, 2015, you see the trend going up. And these are rates in different countries. The one in the middle for European countries, and also including Australia, New Zealand, and Korea for Asia. And the last graph, the one facing you on the right, are actually the countries in the African continent. So even in those countries, we see an increasing trend, maybe except for the Netherlands and Kenya and Zambia. So the trend has been disturbing because in the 1970s, the CS rate was only 5%. And in less than 20 years, the rate has peaked to about 25%. And between the 1970s and in 1987, the increase in the rates of CS has far exceeded any raise in the birth rate during that period. And this last 30 years, we have seen a marked increase in cesarean sections because of the fetal status or the condition of the unborn child within its mother's womb, with the fetus or the unborn baby now as a second important patient aside from the mother during active labor or even antenatally. And this increase is also associated with the use, almost routine, of the electronic fetal monitor. So personally, this has been my concern as an obstetrician gynecologist. And I feel that we have to inform the public and make every one of us here in this platform aware that this is happening and see what we can actually do. Well, in the 1990s, the early part, there has been a slight decrease in the cesarean section rate because there was an increase in the rate of vaginal births after cesarean. Now in the US, cesarean delivery is the most common surgery that's being performed. And in 2016, the rates increased to up to 32%. The reasons for the C-sections being changes in maternal age. So we have mothers who are now older. So women who would rather prioritize a career than starting a family. We have a number of advancements that have allowed high-risk pregnancies or pregnancies that have morbidities or problems, medical problems. For instance, severe hypertension in pregnancy. And advancements have been made so that these pregnancies can continue almost close to term or the right time for them to be delivered. And there are evolving OBGYN practices. Like as I mentioned, almost the routine use of the electronic fetal monitor, and of course, assisted reproductive techniques like in vitro fertilization, while abnormal labor remains the most common reason for the first cesarean section. Now let's see how it is in our country. So these are statistics from the Committee on Nationwide Statistics of the Philippine OBGYN Society from January to August of last year. And using this formula for obtaining the primary cesarean section rate, they noted a primary CS rate of 28% among the 105,357 live births in January to August of 2024. That's for the whole country. And if we go regional, on the other bar graph, you see the different regions and you see rates that are ranging from 22% to as high as 41%. Now this one I obtained with permission, and this is the cesarean section rate tabulation in a Philippine private hospital from December 2023 to December of last year, 2024. And you see the rates are really up, right? So from 35% to as high as 58%. So much so that because of the global concern, the WHO in 2018 has actually released a set of recommendations for non-clinical interventions to reduce unnecessary cesareans. Well, the reason being also because the number of non-medically indicated CS has been increasing. There have been cases where the woman, because of fear of labor, will ask for cesarean section without any reason, but just the fear of going through labor. So this is what we call cesarean delivery per maternal request. And studies have shown that if we do unnecessary surgeries, we are actually exposing our mothers, our patients, and their babies to short and long-term risks if we do not have the appropriate reasons for the surgery. And now we have seen an increase in placenta previa and placenta accreta cases. So what we call the placenta accreta spectrum. The number of cases have rocketed high. Has rocketed high because of the increase in cesarean section. And the placenta accreta spectrum is associated with very bad obstetrical hemorrhage. So I believe there is a need for action and public awareness. And I would like to sound the trumpet call. There has to be a revival that looks into methods and strategies to encourage and support vaginal delivery. And one of these strategies is vaginal birth after CS. Other strategies, of course, will be doing external cephalic version for pregnancies that are presenting in breech or yung persistent breech, yung suhi po ba. So they can actually be repositioned, okay, by the practitioner, okay, so that when the head is down and the patient goes into labor, then her chance for going through labor and progressing and eventually delivering vaginally and normally increases. Also, the use of instruments or instrumental deliveries, like the use of the vacuum cup or the ventus and the obstetric forceps, okay, for addressing second stage abnormalities in labor. So, tanong ng marami, once a CS ba? Always a CS? No, hindi po. Gone are the days na this was how it was. Now po, as you may have sensed, the answer to that is no. And so that's why we're talking about vaginal birth after CS. Ang TOLAC po is trial of labor after CS. So this is allowing a patient with one prior CS or even 2 prior cesareans to go into spontaneous labor, be monitored, hoping for eventual successful vaginal delivery. And VBAC or VDAC is vaginal birth or vaginal delivery after CS. So after good progress in labor, they get into the second stage of labor. Our patient now is ready to push. Despite her scarred uterus, then her chance for cesarean or for vaginal birth after cesarean is there. There are a number of factors that ensure the success of trial of labor after a CS. Younger patients are usually more successful, and mothers who have normal pre-pregnancy body mass index or a good pre-pregnancy weight, a good number of kilos of weight gain throughout antenatal or the pregnancy, a birth weight of a well-grown baby that is average or within the 10th to hopefully less than the 90th percentile of birth weight. Also, the number of previous vaginal deliveries will impact on success. So a patient who has one previous vaginal delivery and then a cesarean has a high possibility of success of delivering vaginally after the prior cesarean. And if that patient, all the more, comes in labor spontaneously without induction or augmentation, comes in at 6 centimeters dilatation, and progresses through the process, then the success for vaginal birth is high. A tried maternal pelvis, so ito yung mga nanganak na po, and nakita natin they were able to go through labor and deliver an adequately sized baby, and they were successful without complications. So you have a tried pelvis, and if that is the condition, then the rate of success is higher. Now, if the patient and her caregiver or healthcare provider decides on TOLAC for this current pregnancy, this has implications for her other pregnancies in the future. So if the CS trial or a VBAC trial after a CS is decided on, there is a decreased risk for placenta accreta spectrum and even a reduced risk for uterine rupture. And as we have seen in our statistics, both private and public training hospitals, there's been a clear association in the number of previous cesarean deliveries and maternal morbidity associated with placenta accreta. Actually, the risk much higher than the fear for uterine rupture. And talking about uterine rupture, kasi yan ang concern ng marami, no? Tora, ayoko ng ma-CS ulit, nakakatakot, baka, masira, mawasak ang matres ko, pumutok. Of course, when that happens, then that's really a catastrophic situation where the baby can die. But when you look at statistics, the risk for uterine rupture after one prior CS is 1%. And if you have 2 prior cesarean sections, the risk for uterine rupture slightly increases. Yes, the risk is there, but the risk is tolerable, if I may say. Of course, there will be patients who will definitely not be candidates for a TOLAC. Okay, now the usual cesarean that an obstetrician gynecologist will do will be the one on the left, a lower uterine segment transverse cesarean section incision, and then double layer repair. Okay, dalawang beses talagang masinsin na sinasara. And if this patient becomes pregnant a second time, with this history of an incision on the uterus, ito po ay sa matres, so hindi po ito yung nakikita natin sa skin ng patient na bikini or pahabang ganon. Magkaiba po yon. This is the uterine incision. So pag ganyan po, the one on the left, candidate po yan. But the one on the right, definitely, we will not even consider or talking about TOLAC, because an upper segment incision, of course, a vertical incision on the uterus, carries with it a very high risk for uterine rupture. Now, I would like to present to you 2 studies, okay? And this is a meta-analysis which reviewed 13 articles. So reviewing trial of labor after CS and elective repeat cesarean. And the review showed no significant differences in the rates of hysterectomy, maternal blood transfusion, infection after delivery, and bleeding after delivery, and even neonatal ICU admissions of the newborns. And this is our local study, the latest one that I've been able to get. Though their TOLAC rate is lower than the usual TOLAC and VBAC rate that's being reported globally, and the VBAC rate is also low. They have noted that patients with successful vaginal birth after CS are the younger patients, as we have mentioned earlier. Those that have less weight and less body mass index, those that have shorter interdelivery intervals, so ideally 18 months between the between the 2 deliveries, and patients who are admitted in active labor, so they do not need to be induced with oxytocin. And the previous cesarean indication was not really an important reason impacting VBAC success. So whether this is a permanent indication dealing with possible cephalopelvic disproportion, so ibig sabihin po parang medyo makipot yung sipit-sipitan, ano po ba? Yun, hindi daw po siya ganun ka-important a reason for success. Kasi meron po mga indications naman na non-recurring. Halimbawa po, the first CS was because of a persistent breach in a patient who is delivering her first baby, or breach in primi. So yun po na CS. But the second pregnancy now, hindi na po suhi. Nakaposisyon po ng tama ang bata, nakacephalic, naka-vertex, tama po yung pasok ng ulo into the mother's vaginal canal. And also the perinatal and maternal morbidities of a successful VBAC against a VBAC that was tried and failed did not differ significantly from each other according to this study. So the overall VBAC success is 60 to 80%. Ang taas na po. So more than half of those will try for TOLAP and hope for a VBAC. Has a possibility of success, 60% of the time. Now let's look at what the Royal College of OBGYN says about this practice and how they actually practice. They have reported higher success rate at 72 to 75%. And they do planning for a VBAC among these patients. Majority of women with a singleton pregnancy. So ibig sabihin po hindi twin, di po ba? Though I've heard of a friend OB who actually did a VBAC for a twin pregnancy, cephalic. Okay, so the ARCOG recommends VBAC for one who has a singleton pregnancy in cephalic presentation, who comes in labor at 37 weeks or beyond, was had a single prior lower segment cesarean section scar or incision. Remember niyo po the one I showed you, yung parang smiley dun sa uterus. And even if this patient has not had a prior vaginal birth, the success rate remains the same, more than 70%. These women should be informed, so the ARCOG informs the woman that elective repeat cesarean section, if this is done without, of course, without TOLAP, is associated with a higher risk for placenta previa and placenta accretus spectrum in future pregnancies. And the possibility of adhesions, kasi nga po nag-opera na po, adhesions complicating future abdominopelvic surgery. One or more prior vaginal births, patients who have had this should be informed that a prior vaginal birth is the best predictor for a successful VBAC. So kung nakapag-vaginal birth na kayo kahit minsan lang, the VBAC success rate actually rises to almost 90%. And the prior vaginal birth history is an independently associated factor associated with a reduced risk of uterine rupture if that is the patient's concern. Now, during the prenatal, it is good practice to recognize early the possibility of placenta previa. So that is the placenta, yung pong inunan or the afterbirth, actually implanting very close to the scar sa lower uterine segment. And if this is recognized, setting a multidisciplinary team or a multidisciplinary approach to tackle the problem, and of course the use of informed consent, so that we have an informed patient and we have boundaries and we are able to reduce our complications. Now, with regard labor pain management, epidural analgesia or anesthesia is not contraindicated. So pwede po, if the reason of the patient for an elective CS is ayoko pong makaramdam ng pain. So there's the option for epidural in a planned VBAC. Although we need to inform them that if they ask for more and more doses of epidural for pain relief, medyo mataas yung suspicion na baka merong impending uterine rupture. And of course, also considering the other signs of uterine rupture. Siyempre, safe po if the birth or the VBAC, the TOLAP, is done in a birth facility, preferably a hospital that has the capacity to perform an emergency cesarean section if the VBAC or the TOLAP fails. Now, the ACOG has actually recommended that for patients who may want to do TOLAP, regardless of the fact that they have limited resources, they can set up there can be a setting where they can be referred to sites or practitioners nearby who can be on standby to offer TOLAC when appropriate. We need informed consent. So the patient has to be informed of the risks and the benefits. And then she will give her signed consent after she has understood everything, all her questions and her anxieties and concerns addressed. She signs and she gives authorization to the attending physician and his or her team to do TOLAC and perform vaginal birth after CS. So, dapat ba CS kaagad? Pwede pong hindi repeat cesarean kaagad. Yes, we can. We can do vaginal birth even after 2 cesareans. Yeah, after 1 CS, pwede po. Yes, we can. And this is actually a friend who is running for her 600th VBAC since she started in 2015 po ata. So almost 10 years after, she's now counting almost 600 VBACs. Galing, ano po? So paano po? How can we actually reduce the CS rates? And sana we can work together and collaborate. We healthcare practitioners, obstetrician, gynecologists, or midwives, if we have nurse midwives in our midst, we need to inform and empower our women so that they are able to make decisions regarding their delivery and help them through a birth plan that they may want to write in preparation for the labor day. The healthcare providers should be ready to offer thorough and accurate information. And wag nating i-reflect yung ating own anxiety about feedback sa patient. Now let's hear them out, okay? And it should really be shared decision-making after analysis of risks and benefits. It would be good for the patient to undergo patient education or childbirth training workshop, and for the physicians to continue to continue medical education and practice according to clinical practice guidelines. Hospital systems in place like a peer review or an audit, a surgical audit with feedback will be helpful, and a mandatory second opinion for cesarean section indications so that we're able to prevent the first CS and not make our patient a CS cripple, and we are able to encourage TOLAC and vaginal birth after CS. This is my last slide, and these are my references. Again, thank you for the opportunity, and I will be ready for your questions.
Thank you very much, Manny, for your very extensive and clear talk. Raymond, what do you think?
Yes, thank you. Thank you so much, Dr. Manny. Marami po tayong ano po doon, no? Napulot po doon. And I think there are also a lot of questions already that are coming in. But before that, we'll give you a breather lang po, no? We'll call you in during our Q&A session. At this point, we'll ask our attendees po, no, to maybe put in where you are watching us from. In the meantime, I'll greet those who are joining us, our avid taga-subaybay and our viewers po, no, all the way from Quezon City Medical Society in Quezon City, Metro Manila, the Cotabato City Office on Health Services, Cotabato City in Maguindanao, Philippine Science High School, Cagayan Valley Campus in Bayumbong, Nueva Vizcaya, Cebu South Medical Center in Talisay, Cebu, Southern Philippines Medical Center in Davao City, Davao del Sur, May Kawayan Doctors Hospital and Medical Center, May Kawayan, Bulacan. Also those who are joining us from Los Baños, Laguna, from Bataan, from Jose R. Reyes Memorial Medical Center, University of Rizal System Health Services Unit, from Marilao, Bulacan, from City Health Office of Antipolo. Thank you so much. Those watching us from Philippine General Hospital, thank you so much po. UP Diliman also. And then I think internationally, there are those who are, meron din po from Makati and then from Rizal Medical Center of Pasig in Taytay, Rizal. And then internationally, those who are joining us all the way from the state of California po, no? I think I saw one earlier from Manteca, if I'm not mistaken po. And then also University of Hail in Kingdom of Saudi Arabia, Kingdom of Saudi Arabia. And then Nam Canto University in Canto City in Vietnam. Island Hospital Penang in Pulau Pinang, Malaysia, and Chuanin Hospital in Taipei City, Taiwan. Okay, and then those pahabol po, Department of Energy, thank you so much. And then DSWD, Haven for the Elderly Medical Services, and Pasig City Health Department. Maraming salamat po. Okay, at this point po, we'll call in our reactor po, no? Our reactor is none other than, and we're very grateful for this one, the Vice Dean of the College of Medicine at St. Luke's Medical Center po, no? Please welcome Dr. Maria Luisa Acu.
Hi, good afternoon. Good afternoon, everyone. Thank you
Good afternoon.
for inviting me to this very prestigious show. Okay, I was tasked to react to what was presented by Dr. Reyes. And I do believe that we can reduce the CS rates by doing TOLAC and vaginal birth after a cesarean. I think the main two things that we have to consider is the provider and the patient. So for us obstetricians, it's really a difficult balancing act and deciding whether this patient should undergo TOLAC or not. And it starts with us because we have to choose the correct candidate. Even if the patient wants it or doesn't want it, then it's the doctor because she knows that the conditions regarding this patient will mean a successful vaginal birth after a cesarean. Okay, so we have to balance. So it's a complex decision making. We balance the medical safety, patient's autonomy, the institutional policies where the CS or the delivery will take place, and of course, the legal considerations. Okay, so Dr. Manny has mentioned that the number one is uterine rupture. So if we think that the conditions will, such as in the vertical classical cesarean section, is high for a uterine rupture, then we don't advise the patient to undergo the cesarean section. I would also say that when we counsel our patients regarding their decision to have a trial of labor after a cesarean or a repeat CS, how we counsel, it should be evidence-based, it should be unbiased, and we should allow her enough time to really think about her decision. It cannot be done just in a single visit. So subsequent prenatal visits, you can still discuss her options regarding a trial of labor after a cesarean. And there are many benefits, as was mentioned by Dr. Manny. And I think the fear for uterine rupture, as she mentioned, is, for me, it's acceptable, 0.5 to 1% according to literature. So as we counsel our patients, we have to tell all these things, and it's up to them really to decide whether they should undergo the repeat trial of a trial of labor after a cesarean. Okay, so we have to select our patients very well, counsel them adequately, and for sure, we will be minimizing the risks and maximizing our success or with regards to the repeat cesareans, the vaginal birth after a cesarean. Also for us obstetricians, we think of the legal concerns because of this climate of litigation. Sometimes we try to avoid this by practicing defensive medicine. And during our counseling, we might do fear-based counseling instead of evidence-based counseling. So it's up to us to police ourselves whenever we counsel our patients. It was mentioned earlier, the informed consent has to be very explicit, accurate, and we have to really help the patient reach a decision whether she will go on with a trial of labor or not. And of course, it was emphasized we never do a trial of labor in just any institution. The hospital has to be one that could do the emergency cesarean section if ever complications do arise. And we have tertiary care institutions who can take care of these high-risk pregnancies. I think I believe I have the same belief as Dr. Manny. We should try to avoid increasing the CS rates because as of now we're getting more and more cases of placenta accreta, which was mentioned earlier, wherein we have abnormally implanted placenta, and usually it's a very bloody problem that we encounter during delivery. Also, we can prevent future surgical complications if we try for a VBAC rather than do a repeat cesarean section. I think those are my comments. I would just welcome any questions that we have from the audience.
All right. Thank you so much, Dr. Aku. And then we'll call in po si Dr. Manny for our Q&A. First question always comes from Ma'am Stella, but we'll wait for Dr. Manny to... Okay, there we go. Ma'am Stella, go ahead.
Yes. So I already texted my message to Dr. Manny, and I think she has already answered.
Sige po, sige po.
Well, uterine rupture is a possible complication. We have to be upfront regarding that possibility. Pero not naman to the point na matatakot yung pasyente. Kasi kung talagang titingnan natin ang stats, ay mapapa naman actually. And because we should be able to select our patients well, hindi natin ipipilit ang hindi pwede talaga. Okay? We do not do TOLAC on classical CS. Scar history, and so of course kapag talagang cephalopelvic disproportion, medyo mas sa mababa yung success rate nila, pero still possible. So the important thing is really selecting our patients, and there will be some things that we will not be able to do when we do VBAC. It would be best if the patients come in labor, but if they get to 41, 42 weeks, tapos prior CS, walang sign ng cervical ripening,
Dilatation.
walang mucus plug, walang bloody show, ang haba-haba ng cervix, ay hindi naman tayo makakagamit ng cervical ripening agents, prostaglandins on patients with scar. Kasi pastukan tayo doon, di ba? And then, well, how about induction or augmentation? Ayun, kailangan, itignan natin yung mga, what are the things on hand as far as this particular patient is concerned. Pero the best really is we have a patient, singleton, at term, with a well-grown baby, no medical complications preferably, just enough weight gain for the whole of pregnancy, coming in labor with one prior low segment cesarean section. The possibility of uterine rupture is 1%.
Thank you very much for your answer, Manny. I also noticed that in my private practice, I really do vaginal delivery after cesarean section. That's a standard to me. It's only when the patients refuse, that's when I go ahead with another cesarean section. Pero I know of exactly two cases, nagkaroon ng placenta accreta, nag-hemorrhage sa OR table, and the patient died. Ganon kabagsik yan. So for those of us who are listening here, that's why I wanted this to be presented, yung TOLAC, because of the very high cesarean section rates in our country, especially in the big hospitals. In the big hospitals, doon mas kasi nga, patients will request for a cesarean section. Ayaw nilang mahirapan sa delivery. So I think that's really that's really a bad thing to happen to our country. It's not correct. Yung isang namatay na patient, doktora yon ha. Yung placenta accreta na nag-hemorrhage on the table. The patient is a doctor and the husband is a doctor too. And she died on the table. My gosh, sobrang tragic niyan. So really, this webinar is very important for all of us, especially those OBs who are there. Lut, I also have a question for you.
Yes, Stel. Should I read it? You sent it
Yes,
to me.
yes, oo.
Your question was about what should we do for patients requesting for a CS, even if there's no indication for it.
Yan.
May
Marami rin yan.
Hindi pasyente na parang sa ngayon, mahirap sagutin. But we have already, in our society, di ba, we have already discussed this issue thoroughly. And based on the last guideline, it's important that we provide unbiased, evidence-based, in-depth counseling, telling them about the benefits and the risks. And of course, it should be clear in the patient's own level of understanding. The informed consent should be, how to say, fit for our patient when we discuss these things with them. In the end, we respect the patient's autonomy. She knows what she wants with her own body. We cannot dictate to her, oh, hindi po pwede yan. Siya yung may katawan, siya yung may anak. So she will eventually, if she chooses that, for our protection naman, she has to have a document. She writes it in her own words, stated there that we have discussed it thoroughly. She knows the risks and the benefits, not only in this pregnancy, but in the future. Her reproductive career in the future, she has to consider it. And when it's written legibly, clearly, and she will sign it, okay, we will do the elective cesarean section. Or maybe this will involve many discussions, and we have to really delve on why she's asking for the CS, even if there's no reason. Maybe we have to discuss her fears or her misunderstanding about the procedure and that kind of vaginal, the birth, the CS, operative CS or delivery. No? Again and again, when we meet our patients during the prenatal checkup, I think it behooves us to discuss these things again and again until she finally reaches that decision. Okay, I will write po a document. Diba, in some sinasabi pa, you have to have it authorized. Ano ba yun? Yung,
Notarized.
Notarized. That's the word, notarized. Para safe naman, we're protected.
Kasi I think one of the fears of patients is pag nag-normal delivery, nag-vaginal birth, the vagina becomes very loose and very wide open. And that can be remedied. You just tell your obstetrician you want it to be tighter after the delivery. So it's not really a problem. So yeah, that's why it's really important that patients, our audience realize na it's not really about maganda tignan yung vagina o hindi maganda. You can die from yung mga placenta accreta na yan. Yun talaga. It should not happen. Should not happen.
I totally agree with you. Once you have dealt with a case of placenta accreta and parang yung dugo tumutulo na parang gripo, you will think back and said, ba't ba na-CS pa to in the first place? Kailangan bang na-CS siya in the first place?
Yes.
Yun ang dapat ikwento natin dyan sa mga patients that would request for a cesarean section even if she doesn't need it.
Stel and Lut,
Hi. Yes, Dr.
Yes,
Marmel.
go ahead po.
tulong siguro pag talagang nag-i-insist yung patient, halimbawa, after you have counseled. Ako kasi personally, pag meron silang isang prior CS history, so at the outset, let's talk about VBAC. ganun ako sa private practice ko. Now, going back naman dun sa CS delivery per maternal request, ito talaga first time mother to be, tapos ayaw talagang mag-labor, no? Takot na takot. Okay naman ang prenatal niya and all. One thing that has been found to be helpful is a mandatory review of ano ba talaga, ano yung condition, at what's the indication. In this case, wala ngang indication, di ba nga?
Na-review na nga eh.
Mother's request. Or maybe a group of other obstetricians can come together and talk with the patient and her family para maallay yung fears niya, maybe maintindihan niya, maibigay yung ibang angles, ibang opinions, and of course the evidences. So yan ang isang nakikita ko among us practitioners in our system. One way to, bring down the cesarean section rates is, ayan, maganda yung peer review at saka mandatorily we review by the first C.
Yeah. Baka may questions from Raymond. Meron ba sa audience? Sorry, hindi ko na-scan na yung audience.
These are coming in from Dr. Joseph Tortona, but I think there's also one. I'll just pick one na lang po just in the interest of time po. No? What is the opinion of our speakers daw po on I think there are VBAC calculators daw po available online. Can those be used by patients? Should they use it in conjunction with their discussions with their OBs daw po? I'm not familiar with this one, so baka mas familiar po kayo dito about VBAC calculators. Coming in from Carlo Mercamanong.
Right. Oy,
From
so
Australia.
many, you answered him. I know Carl Lever. He's a doctor.
Sige po.
Yes,
Oo.
there are VBAC calculators and they can be helpful, but personally, I have not used it. Yan. And sabi din ni Carlo Mer regarding, kasi we were talking about prostaglandin ripening agents. Of course, merong mga balloon catheter that can be used to prepare the cervix for labor. So, pwede naman yun for those that have a uterine scar.
Well, for me, I know there are calculators that you could download from the internet, but personally, I also haven't used it. But I think that scoring system that they have after inputting your data, it will help the pregnant woman to decide whether she'd go for a TOLAC or not.
So parang may formula siya, bale dun from the calculator.
On my point system, for example, she had a previous VBAC, previous vaginal, ang taas ng points noon. Kasi sabi nga ni Doc Manny, that's one of the primary factors why you will have a successful VBAC. Tapos, yun na nga, it was a low segment cesarean section, breach, ano yan? How do we say it? It's the reason for the CS is
non-recurring.
Yes, non-recurring reason. Kaya may point system yun. Kung bata, kung matanda na siya, kung may medical problem, may points. Kaya sa tingin ko, it can help for the patient. But personally, I don't use it. I just gather all the data, circumstances, and then we talk it out with the patient. I also have the same practice with Dr. Manny. Right from the start, if I get from the history, she had a previous CS, then that's part of the initial discussion regarding the possibility of a VBAC.
In our person on the street, there's a patient there na 8 deliveries. Yung 6 of them were all cesarean section. Sabi ko, wow, saan kaya yun na
Na-operahan yan.
na-operahan?
Baka mali ang data ng pasyente.
Nandun sa POPs. Anyway, you can see it later on if you want to review it. Pero I heard it myself. Anyway, back to you, Raymond.
Okay, no problem po, no. The very very interesting discussion. Unfortunately, we're out of time na po, no. At this point, we'll be launching po our evaluation poll. It's 5 questions po, no. It's a 4-point Likert scale, and we'll be asking those who are in the Zoom especially to answer this po, no? So I'll read through them. We won't be closing this until the end of our webinar, but we encourage everyone to put in their feedback. Number one, the panelists demonstrated thorough knowledge of the topic. Number two, the panelists were well prepared and organized. Number three, the panelists spoke clearly and audibly. Number four, the panelists used appropriate language and technical medical jargons adequately explained. And finally, number five, the panelists contributed to new perspectives and knowledge on managing various key health issues. So as mentioned, we will not be closing this until the end of our webinar po, no? For next week, Ma'am Stella, what do we have?
Next week, it is February 14, no? Valentine's
Valentine's.
Day. And we have a special for you. Our speaker is Dr. Gia Pastor-Fide, who will talk on infertility and IVF. Yun naman ang topic natin next week. So for our audience, you want to log in and watch for next week's episode.
Okay. Thank you, Ma'am Stella. In the meantime, you can still watch us on the playback po, no? At the TVUP YouTube channel and at the TVUP Signal TV channel 101. Before we conclude our program, all health updates webinars are archived for viewing at the TVUP YouTube channel. You should just go and open your browser, go to www.youtube.com/TVUPPH, or in the app, open the YouTube app and you go to TVUPPH, you'll be able to see all of our 224 episodes after today. This episode is being live streamed, magiging 225 na po siyang buo for our live tab there in the YouTube channel. We also have in the shorts tab, selected presentations that we feature in snippets, which we call health update shorts po, no? So we hope you'll be able to watch them at your convenience at the TVUP YouTube channel. And then we hope you'll be able to gain nuggets of wisdom from those episodes po natin. Okay? Again, I'll take this opportunity to thank the Department of OBGYN and our colleagues po, no, from St. Luke's Medical Center. Maraming salamat po, Dr. Menifrida Reyes and Dr. Maria Luisa Ako po. This formally closes our webinar for the week. We look forward again to your company next Friday from 12 noon to 1 p.m. It's a date.
Together, we can stop preventable deaths.
So keep safe, keep healthy. See you online.
Thank you, many